Did I put my hand on
Yeah.
Choking. Mike's alive.
Right.
Thank you, Mr. So cute.
Here, Jim. Oh, I was going to turn it off, but it didn't work.
Hey.
Good morning, everyone. My name is Peter Emo. I'm a ROMA board member and the Reeve of the town of Renfrew, and it's my pleasure to welcome you here today as part of the informing you in our rural communities about the modernization in public health. I'm pleased to have with me today Jim Pine, Dr. David Williams, and Allison Blair, and I will go through their biographies. Then Jim will speak, and then Dr. Williams, and then Allison will speak. And then at the end of that period, we'll hold a question and answer session. And I would ask you to limit your questions at that point with the size of the audience to about a minute and a response. We're not going to be able to enter into any kind of a debate format today. It's simply to inform you and also to raise issues that may not have been considered or may have been raised in other forums. So thank you very much for your attention, of course, to the decorum we're going to try and establish and reestablish today. Jim Pine is no stranger to most of us. Jim is currently the Chief Administrative Officer of the County of Hastings. Jim has been in municipal affairs business for nearly 39 years. And he looks remarkably well preserved for that, Jim.
Thanks, Peter.
He has worked as a Chief Administration Officer in small municipalities, as a city administrator, and for the past 17 years has been leading the administration of the County of Hastings. Jim started his career with the Ministry of Municipal Affairs and Housing and served in various positions in his 9 years with the ministry, including as Regional Director for Eastern Ontario. In September 2019, Jim was asked to lead a province-wide consultation with stakeholders on the modernization of public health and emergency health services for the Ministry of Health. The consultation is underway. Jim is also currently one of the co-leads for the Eastern Ontario Regional Network, which has dealt with broadband in the past and is now moving to cell coverage. ERN has an ambitious $175 million project, which it completed in 2015, to improve access to high-speed, high-capacity internet services to more than 425,000 homes and businesses throughout the 50,000 square kilometers that make up Eastern Ontario. A project of the Eastern Ontario Wardens Caucus, and Jim has been an integral part of this project since its earliest days. ERN recently received funding approval for a second project valued at $213 million, and it's designed to improve the mobile broadband cell coverage in Eastern Ontario. Jim is co-chairing the Onward initiative, which includes major municipal staff organizations in Ontario dedicated to promoting local government as a career and supporting succession planning in municipalities across the province. Onward also counts the Association of Municipalities of Ontario and the Ontario Municipal Employees Retirement System, OMERS, as members of this group. Over the course of his career, Jim has taken an active role in municipal advocacy through his work with the Association of Municipalities of Ontario, where he served in a number of roles, including as Secretary-Treasurer and as a member of the Board of Directors. Jim is also a past president of the Ontario Municipal Administrators Association. He has participated in many municipal reform projects, including the Provincial Municipal Fiscal and Services Delivery Review. He has also authored, along with his two panel partners, a wide-ranging review of Ontario's water and wastewater sector entitled Watertight, A Time for Change. Jim Pine. Allison Blair is the Assistant Deputy Minister of the Emergency Health Services Division and Executive Lead for Public Health Modernization in the Ministry of Health. The EHS Division provides and regulates services to all Ontarians, ranging from emergency health services in land and air ambulances to rights advice for patients in psychiatric facilities across the province. Allison previously was the Executive Director of Emergency Health Services Office and the Acting Assistant Deputy Minister, Direct Services Division. Allison brings with her a wealth of experience in strategy development, stakeholder management, and implementation through roles within government and in the health sector. Ms. Allison Blair. Dr. David Williams is currently the Medical Officer of Health for the Province of Ontario and was appointed in February of 2016, February 16th to be exact. Dr. Williams assumed the Interim Chief Medical Officer of Health role on July 1st, 2015, having been in the position of the Medical Officer of Health for the Thunder Bay District Board of Health from October 2011 until June 2015. Prior to that, Dr. Williams had been with the Ministry of Ontario Health and Long-Term Care from 2005 to 2011 as the Associate Chief Medical Officer of Health, Infectious Diseases and Environmental Health Division Director. During this time, he was also the Acting Medical Officer of Health for Ontario from November 2007 until June of 2009. Prior to working at the province, Dr. Williams was the Medical Officer of Health and CEO for the Thunder Bay District Health Unit from 1991 to 2005. Dr. Williams, thank you. So as you can see, we have a very experienced and widely respected panel, and with that, I'll turn it over to Jim Pine.
Thanks very much, Peter, and welcome everybody. It's a large room, but it feels like a small crowd, and that's the way we want it this morning. So there'll be time, as Peter said, for questions. So as we've been saying in the regional sessions, whatever is on your mind, we want to hear. We're always looking for good ideas, so don't be shy. And I know you won't be, knowing all of you over the years, so that's great. Let me start by just saying that I just have a few opening remarks. We want to provide some context, some background context to what we're doing, and Allison and Dr. Williams are going to do that. And then I'm going to walk through some of what we've been hearing in the sessions and the meetings that we've had since the consultation got underway. And then, of course, leave time for your questions if you have any. Let me just start, and I've been doing this at all of the regional sessions because I think it's pretty important. Since I took on this job of working with the ministry in the consultation, I've had a lot of people come up to me and say, is it for real, Jim? Is this really something that the government is paying attention to? And I always answer by saying, I asked that very same question back in August when I was first asked by the minister, and in speaking with Allison and with David, I wanted to be sure that was the case too. And I guess the answer is I did sign on the bottom line to participate, and I am absolutely convinced that this is something that the government really wants to work at and to hear from people who are interested in public health and emergency health services. So when I say that, I also say that means that it's incumbent on all of us who are going to participate to do that, because we've been given an opportunity, I think you heard that from the minister this morning, very loud and clear, that they're committed to this consultation process. So we have a job to do, and that job is to share good ideas with us and with the ministry team, so that when it comes time, as the minister said, to look at what policy directions or changes might be contemplated, we've got the best information and the best advice that all of us can give. So I just wanted to reassure folks that this is worthy of us spending the time together to participate in. It is a reset. We all know what the announcements were this spring, in April, last April, this past spring, and here we are today, talking about public health and emergency health service. It is a reset. There are no preconceived decisions made or directions. That's been made very clear to me. So again, that's why I say let's use the time together to really make this a collaborative approach. I've always found in the work that I've done over the years is the best results that come out of consultations are the ones where we work back and forth. And on that point, once we've gone through the consultation process, we'll talk very briefly about that, through the end of February, a little bit into March probably, then we'll be taking back what we've heard, thinking about policy directions, and then coming back out and saying, here's what the government is thinking. We'll probably do that electronically through webinars or something like that. But I think that's a real amazing commitment that not only are the interests what we're hearing, you're going to get a chance to hear what they're thinking after the consultations. And at the end of the day, I say I think that's the best way to build an improved system, whether it's in public health or emergency health services. So I'm really excited about it. I'm thrilled. It's just amazing to be working with Dr. Williams and with Allison on this effort. We've been going around the province, and I'll talk a little bit about that in a few minutes, I think. So maybe we'll go ahead and some of the slides. Colleen, who's in the back. I'm going to turn it over to Dr. Williams now to give this background or the context around public health. And we'll move to Allison after that.
Okay, well, thank you, Jim. And it's great to be here today as part of the ongoing consultation process, especially with the rural municipalities of Ontario. That's where I had my roots and started from and all that, and lived in many parts of Ontario and have valued that opportunity to do so, and to see the uniqueness and the variability that we see. And that's part of our public health model here. In Ontario, when I started, we had 42, but way before that, we had well over 300 to 400 public health entities, because it was always linked. As one of the first things municipalities did is to have a public health type functionality in there. And so it antedated the Ministry of Health. But the value of that is one that we continue to work on and deal with. And in the diagram you have there, while we talk about a 3-foot stool in the mass and how it's held together, it's more important to understand the dynamic of that and how we've tried to evolve that over the years. What it was when I started in 1991, and when I was taking my studies even earlier, back in 1985, it goes back a while, is the evolution of public health in this time. It has changed, it is changing, and will be changing, because our world is changing, our country's changing, our province is changing, our communities are changing, and our demographics are changing. And that means the value of this 3-legged stool here is important, because all these 3 components have to work very much interactively on different levels without duplicating, but without frustrating each other, and to make sure we're running smooth and efficiently. Having been through and having had lead roles in areas such as SARS, Walkerton, Legionella, listeriosis, pandemic, it was always a challenge to make sure that what was happening in some centers is equally being addressed in rural and communities throughout Ontario, and understand the challenges, but the benefits of having that linkage has been exceptionally important. Adding to that with a Public Health Ontario agency, one of the 3 in the country that has that, we've had 10 years of that. What is it doing? How do we make it even more effective? And how do we go forward on that? So those 3 have been vitally important as we go forward. This work in Ontario is unique in Canada. It's unique in North America, and almost on a global basis, of having this very much iterative, interactive between a ministry-led public health sector, but very much locally driven, run public health linked with municipalities. And the one we've heard clearly, and Jim's going to talk about that, it's the extra value of having that people and communities in the past, while understanding it a bit in the past, knowing some things we did, now we have communities come forward and saying, we want to have that, we need to have that, and we want to keep going. We need the input. How should we do that? How do we prepare ourselves in the future? Let's go to the next slide. So public health has a variety of programs and services, and that's just a slide that gives a few of those. It doesn't mean all the aspects that weigh out in there, the connectivity with the communities, with the various agencies and public groups and volunteer nonprofit groups that they link with to give that dynamic approach overall. In this overall diagram you see there, We've added in that last year, well, 2 years ago now, with the revised Ontario Public Health Standards, with input from the local, with input from our communities, we added in the aspect of, in our health promotion side especially, can we have such a thing as standardized flexibility? That means, can community local public health units decide, based on the data, what is important for the community to do? That has really invigorated the discussion, because communities say, this now means more to us because we can address issues that we think are important, that the data and evidence support is important, and we don't have to have it prescribed from Toronto. Because we can't prescribe everything from Toronto. We need to have this dynamic involvement, and especially dealing with our rural and remote communities. The next slide. In this aspect here, our current state, you can see on the top left, we went from the original slide 35, we're now at 34. Because of January the 1st, we have a new merged health unit here on Perth. And that shows the dynamic of groups coming together, and we applaud that. We have different governance models. What should that be? We have different substantial amount of money, not huge compared to the rest of the ministry, but still substantial. And these are investments that are important. And how do we align our boundaries with our municipalities, with other functional groups that make sense and give us even much more effectiveness in that? So we're looking at that. Ontarians served, you can see the wide variety. Sorry, you're ahead of me, Colleen. I'm trying to cut me off fast. You can see the size variation, and that's why the local is important. Geographical spread, population size, staff size, the whole thing between how do you do ones in a dense urban versus suburban versus rural versus remote. And I'm going to talk about that in a moment. We have a variety of public health workforce. When I started, there was about 3 or 4 cadres. Now there's a wide variety of experts coming to the table, more being trained. How do we utilize that? How do we ensure that's available to all our local ones, all the rural parts of Ontario, as well as to the urban side? Now you can go to the next one, Colleen. And so why modernize public health? We're doing it not because it's broken. Back in 2004-05, after SARS, we had some major issues to deal with. Now we have a fairly strong public health area, as the minister noted in her remarks, but we have inconsistency. Some have good resources, some have less resources. Everybody should have access to the same resources. How do we do that? So we looked at the aspects there on the landscape, we looked around our aspects of partners, and how are we going to do reforms of public health, not only to deal with keeping the strengths, building on the strengths, dealing with the weaknesses, mitigate and overcome those weaknesses, and building for a strong in the next 10 years. Because the minister said our challenge is that we are a strong enough sector now. How do we actually integrate, not integrate into, but integrate in the discussions and planning with the modernized health sector, with Ontario Health Teams, with Ontario Health? We don't have to feel that we are going to be consumed by that, but we do feel we have to contribute to reducing hallway patients. We have done that in the past with our programs and services that sometimes go unnoticed. And we have kept that load off. We feel we can and could do more in that regard through our, as the minister said, prevention and promotion programs. Next slide. So a vision for the service there. One is we want consistency and equity. We do want to have clarity and alignment of roles and responsibilities. What should local do as compared to Public Health Ontario, as compared to the ministry? We don't need to be looking over each other and doing the same thing again and again. How do we do that more effectively and efficiently? How do we have a modernized full sector? So the input is not only for the local, but input, what should we do as a ministry? How do we do that better? What should we do as Public Health Ontario? How do that better? And we talk about improved roles for prevention and promotion, as the minister talked about, and leading in innovative practices, because we've seen that as in the local areas. That's why it's dynamic in Ontario. We have 34 now areas that do various number of projects in their areas that do innovative practice, innovative ideas to say how best you deliver in a rural community, how you deliver in a suburban community, and in a remote community. And that's all exciting. And how we do the health delivery and sustainability of the system. One of the things that's been interesting to me is that the amount that communities have set forward, and they have, and community leaders, municipal leaders have ideas, here's what we would like to have. We want more of this and more of that. As well, it's been interesting this time of consultation, we have added in consulting with our Francophone communities, and we're looking for more and more in that, and with our Indigenous communities. And it's been interesting this time, the Indigenous communities are saying, we might be interested. No, we are interested. We want to talk to you. We've had presentations from some already. We've had urban as well as from Indigenous First Nation communities, and saying, because you have come and started some new things that really resonates with us. You are now talking about community. And we are trying to rebuild our community We want to have that resource available to us. We want to talk about that. How do we position that in the context of Ontario? We want to know how to do that, how to do that better. So those are my comments on that. I'm going to hand things back to Jim. Thank you.
Thanks very much, Dr. Williams. I'll ask Allison now to take you through emergency health.
Wonderful. And great, just a couple of opening remarks. First, thank you for the opportunity to speak with you today. It's wonderful, even looking around the room, how many familiar faces there are, and we've only done 5 of the in-person sessions. I think it's amazing how those in-person sessions can really, when you're sharing your perspectives and we're listening, can bring us closer together. So I'm hoping, Jim said, it's a big room, but it's going to feel like a small room, I think, especially by the end, once we've been able to share our thoughts and you've been able to share yours. We're really looking forward to the next 9 or 10 in-person sessions to be able to get to know each of you and your communities better as well. We also hope, Jim is going to be running through the what we've heard section, and what we're really hoping is that you feel like we heard you. In the Grinch Who Stole Christmas, there's a line that says that the Grinch's heart grew 3 sizes that day. And I think over the course of these sessions, our ears are growing 3 sizes, just because we've really heard a ton from your various communities so far, and we're looking forward to hearing more and more as we go. So I'm going to provide a quick context for emergency health services. For many of you, this is obvious and review, but just in case there are some of you who aren't upper tier municipalities or dedicated delivery agents and don't live and breathe this, we wanted to make sure that everybody had a baseline. We especially know that emergency health services is critical to rural and remote communities, and we've certainly heard in the northern communities that we've visited so far how important it is, especially to First Nation and Indigenous communities as well. So on this slide here, the life-saving frontline services for Ontarians is definitely something that everybody thinks about when we think about emergency health services, but there's also the transportation of medically stable patients within the healthcare system, and we know that this is an issue. Jim will talk more about what we heard in the consultations about that. 50 municipal ambulance services and 6 First Nation ambulance services, 22 ambulance communication centers, plus Orange Air Ambulance are the key partners that deliver these services across Ontario. And overarching legislation of the Ambulance Act is what frames that operation and delivery of the pre-hospital care, including the certification and regulation of paramedics, which happens through the ministry right now. The regional-based hospitals, just in case people hadn't been aware of that, regional-based hospitals play a key role in delegating the authority for paramedics to be able to do what they do when they're seeing patients, and also have a key role in training and education to make sure that we're keeping patients safe and that service quality is high. And in terms of funding, this will be review for many of you. I bet you everybody in the room knows this, that the provincial split is 50-50 between province and municipality, except for some specific services where we provide 100% funding for ambulance communication centers, First Nation paramedic services, and air ambulance services. We can certainly talk about the extra on top of the 50% that municipalities are kicking in when they know that they want to invest in ambulance services as well. We want to also acknowledge the significant transformation that happened with emergency health services in the 1990s when land ambulance services were transferred to municipalities, and we've heard a great deal about the work and the investment of time and energy that municipalities have put into improving these services since that time. And we certainly want to be building on that as we're going forward. Before we go to the next slide, I think it's an exciting time too in emergency health services, where we've just had regulations come into place on November 1st that are going to allow new models of care for selected 911 patients, so that we're having more choice about what paramedics and ambulances can do once they've picked up patients, whether it's taking them to an alternate destination or to permit paramedics treating and referring patients. So we're really looking forward to pilots that are happening across the province on that. On the next slide, it just shows some of the key partners. We've said a lot about these already, so I'll just point out the number of people and providers, frontline providers, that are involved in this. About 9,000 paramedics, that is rounded up from 8,800, and 1,100 ambulance communication officers who are working daily to take the calls, take 911 calls, and then to have paramedics responding to those calls and delivering services. At about $1.7 billion, that's a lot of money that we're spending provincially and municipally, and we want to make sure that we're making the best use of the resources, the paramedic resources that are in your communities, so we're looking forward to talking more about that. So that's a bit of context, and I think we'll turn it back to Jim.
Ooh, thanks, Allison. Thanks very much. So I hope that we'll see that that's just a little bit of context for what's coming next. And just before we get into talking about what we've heard so far, I just want to, because I'm a municipal guy, I need to give a shout out to my county council and county councilors for supporting my participation there's 3 of them sitting right here, so I want to make sure I do that, allowing me to participate in this, and I really, really appreciate it. So, what have we heard so far? We'll go to the next slide, Allison. So as the minister said, and Allison and David have said, we've done a number of in-person regional consultations, we're calling them, in Thunder Bay, Peterborough, Peel, North Bay, and London. And you can see on the right-hand side the 9 that we have left. In fact, we're headed to Kenora on Tuesday night for meetings Wednesday, Thursday, and then back to Toronto for more meetings on Friday. So we're trying to get out as far and wide as we can to talk to people directly. And it's not possible to go to every community, but we're trying to make it so that these locations are at least accessible to most folks. We've had lots of people, as the minister said, there's over 200 so far, folks who have come out and shared their thoughts and their ideas. And I know, of course, that number is going to grow significantly as we do the rest of the sessions. Next slide, Colleen. The other avenue for participation, of course, is through the portal that's been set up for written submissions. And you can see on the slide that we're, I think, over 400 now, approaching 425 individual submissions, both on public health and on EHS. And we would continue to encourage those to happen. It's important. It's a lot of reading to be had, but it's important stuff. So if you've got something to say in writing as a group or an individual, that portal is still open. I'll show you, I think maybe it's the next slide, where we talk a little bit about the timing. Is that the next one? No, okay. So I'll come back to that. So what are we hearing? Let's start with public health. These are sort of what we see as some of the emerging trends that are coming out of the discussions. We'll start with the issue of capacity, and you heard the minister talk about that and David talk about the capacity issue, which is obviously a critically important one in public health. And it varies across the province. I think that's what we expected, and we're finding that as we go around Ontario, that Ontario is not the same everywhere. And that's a message we keep being told. It's not the same everywhere. One size cookie cutter won't work in Ontario. So make sure you understand the regions where you're at when you're hearing. There has been some openness, I think, to ideas around some consolidation, but let me say that is always framed around where it makes sense, and that there's evidence that improved capacity will have the results that we need going forward. So that's out there. People are talking about it, but they're also saying, don't fix something that isn't broken, just for sake of change. Be thoughtful in the way you consider these things, and build upon partnerships that already exist and are working well in your community, in the community. So we're listening very intently to that kind of comment. Okay, next slide. In terms of governance, this is a really interesting one for me. As Dr. Williams said, in Ontario, there are a variety of different governance models in public health. And they've grown up, I think, over the years as the role of municipalities in public health and provincial priorities, I guess, have changed. But one thing is really clear to me, at least, in the discussions we've had so far, is that there is a strong consensus amongst municipalities to have a continued role in public health. Ontario is the only province jurisdiction in Canada where municipalities have a direct role in public health. And as David said, that's because of our long history of municipalities being a part of public health over the years. But the word I'm hearing and we're hearing is they like it, they being municipalities, and want to continue to participate it in some fashion. Finding the right governance model for different boards in different areas is something that we're listening to as well and getting some feedback on. So I think that's just as a common theme. You need to know in the room today that your colleagues are telling us they want to continue to be a part of public health. And they also are saying, it's that last point on the slide, skills-based boards of health are important because of the complexities in public health and the different kinds of issues that public health faces. A good board will be a board that has good skills, and we should be mindful of that in looking at the way forward. Okay? Collaboration and shared resources. I am really excited by the approach that people in public health and who are working in public health, the boards of, represented on boards of health, are saying to us in terms of their interest and their ongoing effort to share resources and collaborate together. I mean, that's one of the strengths of, I think, personally, of public health in Ontario, is that collaboration with the province, with Public Health Ontario, and of course among public health boards themselves and the staff involved to it. There's certainly a strength or a desire for strength and knowledge sharing and exchange. That's a theme that we've been hearing. It's important for best practices to be shared across public health boards and across the community in a better way so that people will have timely access to those kinds of things. And I think that makes a lot of sense. There's a lot of discussion around what role should the province play in that, what role should Public Health Ontario play, and so we're interested in thoughts around that kind of role that can be played. And interesting, as OHTs on Ontario Health start to come into existence and people are thinking about that, the role of public health in that piece is really coming out as an important aspect as well, and we're certainly looking for ideas around what role should public health play in the new Ontario Health world. So that and looking at some of the what we call misalignment in terms, maybe it's provincial and ministerial, or and maybe some local collaboration. So are there ways to do that a little bit better? So collaboration and shared resources, it's a common theme. We do it now, we can do it better. I think that's what I'm hearing. Okay? Roles and responsibilities. I think this is what in my comment just a minute ago, there's certainly a desire for some clear understanding of the roles of public health units themselves. What does Public Health Ontario do? What should be doing? Perhaps to support public health units. How can that interaction be better? And what should the ministry be doing? And I guess in the, as well, the municipal role as well. But certainly there's a lot of interest in trying to clarify those roles and responsibilities. The province probably has, we've been hearing, should have a role in strengthening data collection and the sharing of data. Data is key, particularly I think in outbreak situations, whatever that might be. It's really important that across the province that there's good access to data so that decisions can be made in an evidence-based and an informed way. And with technology changing, we've got some great opportunities perhaps to improve on that. Okay? Funding, now no one's interested in that. We can move on from this slide. Just kidding. Certainly, there are discussions as we're meeting about the cost-sharing arrangements, the announcements that have been made, the impact on municipalities, public health units, and the delivery of frontline services. We're hearing, particularly in Northern Ontario and rural Ontario, don't forget about the geographic challenges that we face. In the north, the distance, I'm from Red Lake, so I'm a northern guy at heart, and every time I get a chance to mention Red Lake, I do. Sorry about that, Allison and David. But the distances really affect the way service is delivered and pose particularly difficult challenges for public health units in the north, and I would say that's similar in rural Ontario as well. Distance is an important factor to be considered in the cost of delivery of public health services, and going forward, we need to pay attention to that. The government needs to pay attention to that. So certainly mindful of that, and I must say that the north shouldn't feel left out in any of this because we're paying strong attention to what's going on in Northern Ontario and, of course, in rural Ontario as well. But it does need to be predictable in terms of the funding. Municipalities and public health units can plan best when they know what the financial picture is going forward. So they're mindful of that, and we'll take that into consideration. Okay? And so that's sort of the themes we're hearing in public health. We'll go to questions in a few minutes, but I'd like to cover off the emergency health side as well. So we'll go to the next slide, Colleen. The minister said it today in her speech, fix dispatch first is the message that she's hearing, and that's certainly the top message we're hearing in our consultations. There are 22 ambulance dispatch centers in Ontario, and they need to be, some of them, most of them I would say, need to be modernized to take advantage of the technology and the techniques for dispatch that will improve the way we manage and operate our land ambulance and air ambulance, I guess, dispatch or services. So that it's really said, if you have to fix that first before you can think about other things, and that's a message that keeps coming to us. But we're also hearing that the sharing of data is really key, and communications amongst providers is critical, and there needs to be significant improvement so that services can, whether it's air ambulance or other services in the ground, on the ground, can talk with each other in real-time situations. So again, you need to fix some of that stuff in terms of the technology. And I should say that Allison will say this, I'm sure, is that is certainly something that the ministry is engaged in right now. In terms of the modernization of dispatch. I think from a municipal point of view, what we're hearing is make that done as quickly as possible, because that's key to improving the service. You know, I found in my own work with my EMS chief and his staff that the paramedic services are very much interested in making good use of new technologies that become available in a quick and efficient way. And so there's lots to be gained by listening to what they have to offer in terms of those suggestions. So fix dispatch first has been the primary message we've gotten so far on EMS. Okay? The other thing, very clearly, is that municipalities are absolutely wedded to being a part of the delivery of paramedic services, want to continue to do that. Most of you will remember back in, I think it was the year 2000, when the transfer of land ambulance responsibilities were made by the province to the sector. And since then, we've all, and including, of course, the province, have invested significantly in upgrading and modernizing paramedic services across the province. And as a result, municipalities want to continue to be engaged in delivery of that particular service. They're well committed to it. So that's a message that's loud and clear. I think, again, and the minister mentioned this, in rural communities, the challenge of distance and dispersed population makes the delivery of land ambulance services a challenge. But equally, in urban communities, we've got matters to deal with as well. We'll talk about those in the next couple of slides. So, bottom line, municipalities want to continue to be, at least what I'm hearing, involved in the delivery of paramedic services. Okay. I think the minister mentioned this, and Allison has mentioned it, the importance of integrated care. Really, it's about the patient at the end of the day is the primary objective in all of this health transformation, I think, that is being considered. It's about the patients that we serve, or the people that we serve in Ontario, and there needs to be support for new approaches, and that's certainly happening. I'm learning a lot as I go through this consultation. The changes that have been made in regulations to the statute that allows for diversion to an appropriate facility rather than a hospital for some patients is a key step forward. The ability to treat and release, I guess, or alternate destinations, those things, and there's some examples on the slide. All of those things are important to the efficient and improved operation of paramedic services, but more importantly, I think, important to the patient. So that kind of new flexibility that's built in, I think over time is going to make a significant change, but we're hearing more that paramedic services want to make good use of those opportunities. The other thing, and the minister mentioned this as well, the importance of paramedic services being able to see in that second bullet point, patient histories or records in real time. That is a key technology improvement that needs to be made in order to, again, better serve the system as a whole. So that seamless kind of approach to sharing patient data is something, it's a message that we're hearing strongly as we go through the regional sessions. And certainly, the issue of community paramedicine is front and center often in the discussions that we've had on a regional basis when we've been doing these regional sessions. That community paramedicine is something that offers some benefit to the whole system as well, how we work that out at the end of the day, but they're the strong notion that we're hearing around the support for community paramedicine in an expanded way as well. So community paramedicine is on the top of the list that we're hearing as well. Okay. Offload delays, what I'm learning as I go around the province, in some areas it's less of a concern, largely because there are a number of alternatives, patient transfer services in some of the larger communities that don't exist in other parts of Ontario where there's fewer or perhaps none. So offload delay is a key to getting ambulances back into the community to be ready to serve an emergency situation. And so we're hearing about techniques or ideas to improve that situation. And we've had some interesting discussions of the way non-urgent patient transfers or medically stable patient transfers can contribute to improving offload delay times as well. So very much the paramedic services are working with hospitals to try and improve those situations, and we are being told more needs to be done to help end that. And I think that'll help with hallway medicine as well. Next slide. The other thing that, and I think this is really important because all of us as providers of paramedic services and others in the healthcare business are concerned about our employees and the mental health of our employees. Paramedics and others face very challenging daily situations in dealing with responding to emergencies. And this causes stress on the employees, and as employers, we're always concerned about that, obviously. PTSD and other disorders are a problem for us, and that's what that really means is that we've got some significant challenges for our employees to help them. And so how can we do that? And there are some things that we need to look at, like in the bottom, the standard for responding to and supporting people with PTSD, first responders. So we're hearing more about it, and we're interested in hearing more about that as well as we go through our sessions. But there's no question that we all are concerned about the toll that the work takes on our employees. Okay? I mentioned this just a minute ago, transferring medically stable patients. This is a biggie, I guess, if I can call it, in terms of what we continue to hear as we go through the sessions we've been at anyway, in that it's particularly important for rural and northern communities in terms of making sure that there's access to transportation services for medically stable patients who don't necessarily need an ambulance to do that. There's got to be a better way to support the movement of those patients. We've heard some interesting stuff from Orange, the air ambulance service provider, about this issue of medically stable patient transfers. They are aware that, I think they authorize, do they not, if I get that right, that all of these transfers. They know exactly what's going on across the province. They have the responsibility for tracking those non-urgent transfers. Maybe we'll hear something from them that will give us some ideas around how to make it better for the paramedic services, generally speaking. And if, of course, you can move medically stable patients, say, from hospitals back into the community, that's very important to offload delays, but it's also very important to making sure that people coming into the system, into the hospital system, who need to be there, get beds and you know, make it that much more efficient. So if there's ideas about, other ideas around this particular issue, we're all ears for sure, and look forward to those ideas that may be coming along. Key issue. So before we go to questions, which we're going to do in just a second, this is just the consultation timeline, just as a bit of a wrap up. So we started the official consultation on November 18th with a webinar. Some of you may have watched that. The three of us participated in it. We've started the in-person consultations. Today is the check-in day with ROMA as to what we've heard so far. And then we'll continue working, as you've seen in earlier slides, through the regional sessions. The slide also says that February 10th is sort of the closing date for getting your comments in. I think there's probably a little bit of flexibility in that, particularly for folks who we haven't had a chance to meet with in person first. They may be interested in providing that after we've had our meetings with them. So, but that's generally around the timeline. And then into March and the spring, I guess we'll be taking back, the ministry will be taking about what we've heard, and thinking about what's next. So, that's a lot of talking. Now it's time to take questions. Peter?
Perfect. Thank you, Jim. I should note, the information will be available on the website as soon as possible. Now, I have to confess, I walked by the computer in the back. I can't, you know, and I can wipe things very quickly just by looking at it, so I can't give you any timelines when it'll be there. We're also video and audio taping this, so the information will be out there as well. This is a very significant concern, issue, opportunity to rebuild the system as we know it today, and ROMA has taken it very seriously, as has AMO, and we've had great support from Brian, the Executive Director, from Petra, the Member Services Director, from Monica in Policy. Monica's here today, as well as Matt from AMO, so we're very fortunate to have their support. AMO's board is very engaged in this as well. So thank you to the two respective boards. We're taking the opportunity to meet with Jim over the next couple of days as well, so Jim's going to get very sick of hearing my voice. I apologize to you, Jim, for that.
I always like listening to you, Peter.
Yeah, yes, Jim, I know that. And so we will be issuing those, our position papers, you know, within the next 10 to 14 days, likely as soon as they go through the board process and get tailored a little bit. With that, I'm going to do a very poor imitation of Nigel. We're going to ask for questions from the mics, basically about a minute, if you don't mind, not too much preamble, and it's essentially for you to ask questions and provide some information. We know this is very important to our friends in our many communities in rural and northern Ontario, and it's good to see our board members from FONAM and NOMA here as well. So with that, I'll start with mic number one, sir. Please identify your name and your municipality as well.
Hi, I'm Peter McKenna from Smiths Falls, and I'm also the representative on the Public Health Board. My question is, can you describe efforts that you've taken already or that you plan to take to involve the actual service user? These comments it's fairly technical, and people inside the system seem to be the most outspoken, understandably, but the person who's riding in the ambulance or the person receiving the public health services, are there efforts that you're planning that could involve the families, patients, or service users in the consultations?
Thanks, Peter. Thanks, Peter. That's a very good question. We have been talking to the folks who are delivering, I guess, and involved in governing public health generally in EHS. We haven't done public meetings per se at this stage, given the timelines and frankly, the amount of stakeholder interest that we have in terms of the services themselves. So we haven't gone out and done public, wide-ranging public meetings, and I'm not sure that we have the time to do that. But we are meeting with and talking to frontline workers who are involved in the delivery of services, their union representatives, provincially, nationally, and some of the locals to try and get some of that flavor. I don't know, Alison, did you want to add anything to that, or David?
I think, just to clarify, very soon we will be able to say, these are the meetings that we're holding with frontline workers, but at this point we're still working those out. We expect that we'll do a combination of some webinars to make sure that we can catch people when they aren't working, when they're off shift, and potentially some in-person meetings that we're working with the unions about how we do that. But it's an excellent point. Appreciate it.
If I can say, Peter, as well, in all of the sessions that we've had, the people who we've been meeting with have been voicing very clearly what they see are some of the people who use the system, or patients or whatever, their interests and the residents. So we're getting a pretty good flavor of it, I think. So hopefully that gives you some comfort.
Great, thank you. Microphone 2, please. Ron?
Ron Vanderwall, Mayor of South Frontenac. I don't need an answer. I just want to make 2 comments. One, that when you're looking at the restructuring or the dispatch of ambulance, I agree that they need to not wait at the hospitals and all that so long. However, I don't want it to impact our volunteer firefighter services more than what it is now, because 60 and 70% of our calls are medical. So I also, if they're changing the system, I don't have a problem with that, but I don't want more impact on our volunteer fire system. So I just want you to keep that in mind.
Okay.
And the second, I also want you to have regard for what social services in our community, as Southern Frontenac Community Services, North Frontenac Community Services, what the impact in the healthcare of prevention and keeping seniors in their home has when you're looking at these new models. That's only my 2 comments. So, but I am encouraged by the panel that they're looking at the rural, and I think keep up the good work, and hopefully we get some good answers out of it. Thank you.
Thank you, Ron.
Thanks very much, Ron. I should say on the social services side, Ron, just to give you some comfort, we're hearing that very clearly as well.
Thank you. Microphone 1, Michael?
Thank you very much, Peter. I'm Michael Donahue. I chair the Health Committee at the County of Renfrew. And one of the things that I want to, in the preamble, if you will, is we're quite engaged in the hydra that is health across so many different components of the healthcare system in Ontario right now. I'm very pleased to do so, actually. And for everyone's consideration, within the County of Renfrew, the County of Renfrew is the 2nd largest funder of healthcare in the county. The largest is the Pembroke Regional Hospital with a budget of $90 million, and ours with long-term care, paramedic services, and public health is in the order of $50 million. We're players. We're going to be at the table. I'm also pleased and satisfied also, Mr. Pine, when you say that we wish to continue to be parties on the public health side. We're going from being a $1.5 million party to about a $2 million party. My question right now, though, is with respect to the paramedic services, and I'm very pleased that in this report that you put forward today in the slides, community paramedicine is enormous in our rural and remote community, and we have a very innovative paramedic service. Is this, though, this was not a component to Minister Elliott's comments, and I certainly will speak to this in the Bear Pit, hopefully. I'm hoping that this is very high on Minister Elliott's radar, because this is something that's having an impact on hallway health right now, and we can do something right now. And we're also in need of family physicians. This is how we're making healthcare accessible in our community. Is this high on the radar within the ministry?
I think the best person to try and answer that question is next to me.
Great. I think certainly when we've spoken to the minister about how much interest and attention and excitement community paramedicine is taking on in municipalities, and we're hearing that elsewhere across the province, not just in Renfrew, but there's certainly a lot of interest in how can this work. The minister understands the importance of this, and also about how Ontario health teams can be leveraging this kind of service, the community paramedicine service. So I think the discussion that we're looking to have is, how can these community paramedicine projects, and our understanding is that there are 140 different services that are provided across the province. How can these be linked into the coordination of care and collaborative care that's happening with Ontario health teams? So I think that's definitely on the top of Minister Elliott's mind. And we've also heard from some other cabinet members about their interest in it as well, I think because they're seeing the successes within their local communities. And that's what we've heard most importantly in the in-person sessions so far, is how much municipalities are relying on this to avoid 911 calls and to make sure that we're preventing those if we're taking care of people in the community. So I think it's fair to say that although the minister didn't mention community paramedicine this morning, that she is definitely conversant in the benefits and the interest in municipalities have in this.
Great. Thank you, Ms. Jones. Ms. Blair, sorry. With that, Dennis, mic two.
Yes, Peter, thank you. And thank you to Allison, Jim, and David for attending today. I'm the mayor of Frontenac Islands and also the chair of our regional health board, Kingston, Frontenac, Lennox, and Addington. And this discussion is not new for us. Actually, after Cynthia St. John's and the group around St. Thomas and Oxford, London area amalgamated, we've been in discussion with our joining health units, the Hastings and the Leeds and Grenville. And we've come across a number of commonalities where we know that we can combine functions. Perhaps one area looks after IT, another back office finance, another data collection and that kind of thing. But as we get more serious now, preparing for your meeting on February 5th, we realize that not all of us provide the same services. For example, ours and Leeds and Grenville provide septic inspection and new building approvals for septic tanks, whereas the Hastings County doesn't. So I'm a little concerned how we would transition that kind of activity, and would we be getting some experts in to help us how to bring it back either under the municipalities that are involved through the building inspection, or as it was years ago under the Conservation Authority. Thank you.
Thanks very much, Dennis. I guess, David, did you want to say anything?
Yes, and thank you for those comments. And I think that shows you that we have a variety of different things that health units do and areas of expertise. The so-called septic tank land development, Part 8, has been done in different ways in different health units across the province, and some have been in and out and changed, and as they try to link with your municipal counterparts on how best to do that. So we're looking for ideas. How might those aspects be dealt with? Is it best still within the public health venue? Where should be, and those that are not partaking, how do you arrange that? So thank you for bringing that issue. We haven't heard that one in particular, but that's just one of many different things, excuse me, that health units do in different ways across the wide breadth of Ontario. And so we need to be aware of those.
You're right, there's lots of others.
Yeah. Thanks, Dennis.
Thank you. Mic number one, we have about 25 minutes left, so if we can just step it along a little bit, because I want to make sure I get to my friend Roger from Northern Ontario. And he's at the back.
Hi, my name is Judy Brown from the town of Perth in Eastern Ontario. I have two questions. We spoke of hallway health and getting people into beds. A few years ago, ours is a two-site hospital, Perth and Smiths Falls. A few years ago, in order to balance the budget, we had to close down 6 beds at each site. So I'm wondering if the funding allocation that was recently done several weeks ago, if the parameters of it would allow for something like opening up beds again. My second question is, you spoke of municipalities wanting to be involved in healthcare. Recently, even as everybody knows, that the ministry, the province only funds bricks and mortar, anything like CAT scans and machines and so on. The money has to be raised locally. We have a very active and very successful community foundation, hospital foundation. However, last year that they found the expenses of new equipment were running so high that they have come and asked the municipalities that they serve to contribute to health care. So last year for Perth, it was $97,000, which is a 1.5% tax increase. So I'm wondering if there is any possible change that the province would contribute to the equipment inside the walls as well as the brick and mortar. Municipalities right now are facing tremendous challenges with costs that we didn't have before, and this is certainly included as one of them.
It's going to be the least helpful answer that I'll provide today, I think, which is that on the use of funds that were previously announced for beds, I think that's something that you'll need to talk to the hospitals area about, that I'm just not able to comment on it. And the same thing about will the province be changing how contributions to infrastructure are done. I think that's something that you can direct the question to the minister, and I'm sure she can get back to you through the right area in the ministry. Sorry, I'm not it. I don't have the answer.
I guess the short answer is kind of out of the scope of what we've been asked to consult on it, so. Yeah. Yep, no, very good. Thank you.
Thank you. Mic number 2, please.
Thank you. My name is Matthew Graham, Deputy Mayor of Cav-Monaghan. Nice to see everyone again. I participated in the Peterborough consultation, and it was very fruitful. So, and for all those looking forward to the future ones, I hope you participate fruitfully like we did. My exciting question is about legislation. The existing legislation governing the Foundation of Health Units in Section 77 of the Health and Promotion and Protections Act insinuates or states that when new units are formed or merged, the assets and liabilities of those pre-existing units become assumed by the new entity without compensation. So that, I know there's issues with regards to funding in the future, but the monies that have been funded in the past also are a huge contribution from the local taxpayer in regards to the services that we're intending to receive from it. So I brought that up with regards to in our public consultation process, but I just wanted to raise it again here if it's not something that's at the forefront of other units' minds. It's a real reality resulting in millions of dollars being transferred to the province for a lot of municipalities, and I didn't know if there had been anything or any developments on that point, as I didn't see it reflected in the slides, but thank you.
I think the answer to that is that we certainly heard that, Matt, when we were in Peterborough, and it may not have made it to the slide, but it's certainly in the, we understand what you're saying. Yeah.
Thank you. Mic 1, please.
Thank you very much. I'm Andy Mitchell. I'm the Deputy Warden of Peterborough County, but also the Chair of the Public Health Board. And so first of all, I want to express a very deep appreciation to the three of you for the work that you're doing on the consultations. I suspect this is in addition to, not in replace of, your other duties. So thank you very much. And as Matt mentioned, we appreciated that you came to Peterborough. I have a couple of questions, though, in part based on what the minister had said earlier today. The first has to do with the timing of change. When Jim and others, when you were in Peterborough, you talked about there being a blank canvas. Nothing was cast in stone. From Peterborough's perspective, we're going to do the best job we can to help you paint that canvas with some principles and ideas that we think are important. But the minister, if I heard her correctly, alluded to, I'm looking forward to the consultation through to the end of February. I think I heard her say that. And so that got me thinking, well, there's a fiscal year end that looms on March 31st, and is the idea to try to get some proposals out there, either in conjunction with the 2020-21 budget or with the change in the fiscal year. So that was one part of it. The other part of it, and the minister, and I think eloquently and passionately talked about the issue of equity, and that it was important that a resident of a rural community through public health have the same access perhaps as somebody who's in a large urban center. Part of the challenge with it, though, is on the financial side. And it's challenging for me to figure out how you can square what basically is a large transfer of financial responsibility to municipalities who have a very varied capacity, and in some cases a very limited capacity, and square that with trying to have a more equitable playing field. The two just don't seem to be congruent. And so in terms of timing, we need to know whether or not we're facing that 90% increase for 2021. And I don't know whether you can give any insight on that.
Thank you.
This is a great one for me to pass over.
I guess I'm up. On the timing of change, we'll do that question first. I think the minister said end of February because that's where we're aiming to get the in-person consultations wrapped up. I think she also said that we would be looking at bringing things forward for government approval. And then Jim was talking about coming back out to you. So the picture, the path that I think we're forging over the next little while is to make sure that we've heard from you at least in the first round by end of February. And then to be thinking about it, as Jim said, maybe testing some ideas based on what we've heard from all of you. And then, of course, we've got to seek government approvals. So I don't see that would necessarily be possible before the budget is released. One can, let's see how it goes. But that's not what we've been telegraphing from the panel to the minister at this point. So in terms of timing, I think that's hopefully that's some assurance. And on the issue of equity of access and the financial challenges, I think we are certainly hearing about the financial challenges. It doesn't change our goal of wanting equity of access and equity of outcome, even to take it even further from a public health perspective. So that's something I think we're going to need to continue to speak about. I think if the minister were asked about the financial challenges in the out years, she would say, let's have a conversation at these consultations about how we can do things differently, and then we can understand the budgets for the out years. But you can ask her, and we can see how my answer and her answer line up.
Thank you. Mic number 2, please.
Thank you. Good morning. My name is Sandra Hollingsworth. I'm a registered nurse, but I'm also a city councillor from Sault Ste. Marie. And in my previous life, I worked for the College of Family Physicians of Canada. So I feel like I have a good sense of the healthcare system to this date. I'm happy and want to say thank you that you're looking at the paramedic piece. I believe you call it the community paramedicine. I do have a suggestion, but before I jump into the question/suggestion, I would like to encourage you, I know you're on a time deadline, but to encourage you to speak to families or patients. 2 quick scenarios. As a registered nurse, I deal with retirement homes and also seniors that are trying to live at home. What's happening is that they're having common problems such as dehydration. We have seniors that are whisked off to the hospital for just an IV to dehydrate. Why can't we be more consistent across the board in our retirement homes where IV fluids can be given? Second thing, the other piece is we have seniors that have UI, urinary tract infections. They are whisked off to the hospital for antibiotics, and then they have to follow up with antibiotics IV for the next 5 days. Again, why can't we be consistent where IV antibiotics is given at retirement homes or in their homes? Not all community nurses are available. Not all rural areas have these community nurses. Hence, what the outcome is that you're backing up the ERs. And last question, the main question is, what's going to be the scope of practice for paramedics? And I believe it's down in the United States. There are some positives in the United States. That some paramedics can call into a base where they have a physician or a nurse practitioner that can give orders to, again, prevent them from coming to the ER. So again, it goes back to, are you looking at the scope of practice? Is there a chance that a superintendent, instead of the paramedic supervisor running around a car, you may have a physician or a nurse practitioner running around the car to link up with your paramedic team for these more complicated cases? Thank you. Again, I appreciate what all of you are doing. It's excellent. We're getting there.
that's loud. Thanks, Sandra. I think it's a really important question, and we've definitely taken note about the where certain kinds of services can be provided, and also the ability in some communities to have, for example, home IV antibiotics and not in others from an equity perspective. On the scope of paramedics, right now we're in the midst of, right now there's a standard on patient care models that is posted for comment, I think until it's mid this week, I think, that we've asked for comments on a standard that would allow paramedics to do different things for patients. And so this looks at transporting them to alternate destinations. It looks at being able to treat and refer patients, for example, to a palliative care team or that kind of thing. And we're certainly looking for the results of those pilots to inform what the scope ought to be and how also we plan to oversee that from a medical perspective. Right now we have the base hospitals that provide that kind of service that paramedics can patch into and speak to a transport medicine physician. Same thing with air ambulance. And so that's a model that we work with now, which is different from having them driving around in the vehicles. We do have situations where other practitioners, whether they be occupational therapists or mental health nurses, are working closely with paramedics to be able to provide certainly what Niagara is calling mobile integrated health teams. So I think we are looking at what those alternatives are and trying to develop standards so that we can make sure that that's always safe for patients as we learn and implement them in Ontario.
Great, thank you. With that, we have about 15 minutes left, and so we'll close the lines off where they are right now. And my friend Roger from Northern Ontario.
Hi. Yes, my name is Roger Sigouin, Mayor of Town of Hearst, chair of the Foyer des Pionniers in Hearst for at least 15 years. We're about 6 hours east and 6 hours west from Sudbury to Thunder Bay. And we do have some Francophone, and with respect to English-speaking people there, we do have some Francophone hospital in the north, and even on the east side as well. And I was just wondering there how we're going to be involved in the process as well as Francophone. When I'm talking about Francophone, a lot of my people there, they don't understand a word in English. They don't even speak the language. So most of the time when you want to give a service to those people, I think you need the right regulation in place. And I'm the chair of the Francophone municipality in Ontario as well. So I'm just looking forward to be involved in the process as the chairman and see what we could do to improve our service. By the way, we don't even have 24-hour service on ambulance in Hearst. And we're not the only one as well. So that's something we have to look forward to try to improve that. Thank you very much.
First, let's talk about the Francophone involvement in the consultations so far. What we have been doing is the networks and the entities, les entités et les réseaux, are invited to the sessions, and they have participated in all of them. Colleen's behind the curtain, and she would be able to say how many of them, but I think it's been all 5. And often these organizations are raising the importance of being able to care for somebody in their home language. Within the 911 system, we do have a translation service, so that's something that happens, but as the representatives from the entité have told us, that's not always good enough. And so when you're talking about public health services and paramedic services, we want to make sure that we've got local people who can speak the language, especially if you're in a crisis situation. So that's definitely something that we're hearing. That said, we're very open to how to make sure that we have perspectives from Francophones incorporated into the consultations beyond what's happening in the in-person sessions.
Roger, and I'm very sure that they will reach out to you now that you brought the issue forward. Thank you.
Good to see you again. That drive always from Hearst to Long Lac's a long one. And so many times. I think what we want to do as part of the consultation process, ask those questions. What should we ensure that's in place as far as skill base and training and resources? How can we take advantage of IT that might overcome and deal with better, especially with broadband? Even areas we've been looking at on, for example, between Ontario and Quebec, with our agencies, that the INSPQ in Quebec said, if you need us, we can help and assist in that way as well. So we want to make sure we avail ourselves to as many resources as we can so that we can overcome barriers. But the key thing is we need to know continual feedback from the Francophone community, what is working, what's not working, what can we do better. So that's part of the process.
Just one last thing, Roger, again, like others, I would certainly encourage some written submission from the association. If you wanted to do that, I think we certainly would welcome that. So that's another opportunity as well. So that would be great. Thanks.
And I will link you with by email, Roger, with Jim by lunchtime. Thanks. Mic number 2, please.
Yes, Tom DeLine, Center Hastings, and welcome to Toronto, Jim. Glad to have you out here.
It's good to see you, Tom. He's one of my counselors.
Well, right now he's good for to see me. We'll see when I'm done here.
Oh.
But I'll talk about my little
Sounds like a regular
municipality, and
council
really
meeting.
it's going to stretch back quickly, and I'll try to be very quickly here, but it's going to come back to dispatch and protocol is really where it's going to come back to. But I'm very proud of our municipality. We've spent some very good money invested in healthcare in our municipality, like a 18,000 square foot medical center building that now houses 4 doctors thanks to some help from the county, 2 nurse practitioners, dentistry, you name it. We've got even 2 days a week for x-ray, an air ambulance helipad, and we have a county ambulance base at the back of our fire hall. So dispatch and protocol is something I would really like you to try to have a look at. 90% of our calls are medical calls through our fire department. We have 2 halls, 40 roughly volunteer firefighters, so you know what happens. You don't call one hall, you don't call one segment. When that call comes in from dispatch, both halls. So in most cases, we've got 4 vehicles, okay, and $1,600 going out the door, and lots of times, 90% of the times, they're stood down before they get to the call. Now, don't take me wrong, we want to be there when the call is a real one. But if you could really look at one thing, it's a protocol of how those calls, what level it is that calls out those services, because that service for a small municipality like ours is very costly. We don't want to not go and help somebody that needs a problem. We certainly don't want to not go to an accident where somebody really needs some jaws of life or whatever, or the backup thing. But if you, it's not really a question, it's just a foresight to have a hard look when you're talking about dispatch. Have a look at the protocol of how it's dispatched to a small rural community that provides the auxiliary service like we do. It's very costly to us to do that. We certainly don't want somebody to die because we don't go. But we certainly want to have a look and see what that protocol is, how maybe that could be revamped a little better. It seems odd to me, we've got 4 trucks and less than 2 or 3 minutes or 4 minutes from a call coming in, and it's a stand down.
Great, thank you.
So if you would look at that, I'd really appreciate it. Thank you. Jim, good luck to you.
Thanks, Tom.
Thank you.
That's similar in a way, I think, to the comment that Mayor Ron Vanderwall had made a little bit earlier, but I know Alison wants to say something.
Well, I think it's that we're really looking forward to the discussions as we implement new technology for triaging calls that will allow us to get more granular about what the medical need truly is. But what I'll say, and Chief Peter Dundas and Chief Greg Sage are sitting right back there. Give us a wave. Okay, maybe. Okay, there you go. They did. Who are working with the Mississauga Ambulance Communication Center very closely as we're looking to implement that this year in 2020. And they're having to decide for all these types of calls, and there are thousands of determinants, what services should be sent. And within that, a supervisor vehicle or an ambulance and when fire should be called. And so that's something that I think municipally they're going to be bringing to their councils to be discussing how that's implemented and what the protocols are. So I think over the course of the next little while, as we implement the medical priority dispatch system, you will be involved in discussions about those protocols.
Great, thank you. 8 minutes. Microphone 1, quickly, please.
Thank you. My name is Ted Smith. I'm the Deputy Mayor of the Township of Brock and the north end of the region of Durham, and as the Deputy Mayor, I also sit as Regional Councillor at the region of Durham. We have a volunteer fire department in our municipality, and just in partial response to the previous question, we've had tiered response from our dispatch, which is administered by the region of Durham, tiered response that has probably given us at least a 30% reduction in our fire calls because they're only sent out when they're needed, and I guess I assumed that was province-wide. It doesn't sound like it is. So I'll just also mention that the biggest issue facing the EMS services in Durham, in the region of Durham, is the offload times. That's been really significant in Durham. The amount of time that the EMS people spend at the hospitals that is forcing us to have more ambulances because the others are sitting there doing nothing. So my question, on a completely different topic, I'm also the chair of our local community health center, the Brock Community Health Center, which has no municipal affiliation, but so I guess I know enough about healthcare to be dangerous. We've had the LHINs. I think there was 14 LHINs across the province. We know they weren't perfect. I'm not here to defend them, but at least we knew what they were. We now have the creation of, my perception anyway, is of 10 Ontario health teams, I think they're called, in which the ministry has said, okay, this bunch over here, talk among yourselves and devise a program with essentially, as I understand it, very little direction or supervision from the province. So to me, that's going to end up with 10 potentially diverse Ontario health teams with different protocols and different structures. How is that going to help municipalities cope and deal with them and give long-term structure to anything when we at least knew what we had before, and now it could be all up in the air?
TBT, to be determined. But anyway, Jim?
Yeah, I know. That's my concern.
Thank you.
Go ahead.
I think the questions are important ones as we go through the wider sector, the health sector modernization, with the formation of Ontario Health as the agency. And that's still in early days with the CEO just appointed and other things moving ahead. So there's much to move in the next number of years. Add to that the OHTs, the Ontario teams, there's actually 24 appointed as the first wave. There's probably more to follow. That's another one that's evolving under another ADM that has leading that process as well. So there's a number of aspects within our ministry that are undertaking this, including ADM totally responsible for sector transformation. So a lot of work that the deputy's involved with, as well as the minister, of key priorities. So there's much, as you alluded to there, we have to work at and go forward on. So I think stay tuned, and we'll be updating, and those ADMs will be updating as soon as they can on the different aspects and hearing the feedback that's important so we can build a stronger system as we go ahead. Alison, you have any comments?
Just a couple of comments. As Ontario health teams evolve and mature, and I would say not 10 of them, in fact 24 have been announced so far, at least another 30 are in development. And I can understand the uncertainty about how are we going to deal with these Ontario health teams. And the feedback that we've got at the in-person sessions so far is be at the table and help to shape that. I think that Ontario health teams won't immediately shape how services or through which organizations services are delivered, But I think the collaboration and the coordination, you can only benefit from being around that table and understanding what the local communities are thinking. And I can understand the uncertainty, but I think as these evolve, it will be helpful to your communities if you're at the table, both from the emergency health services perspective and public health. And my understanding, based on the in-person consultation sessions that we've had, is there is some variability about level of involvement, but all are aware and are communicating with the Ontario Health teams as they form. So looking forward to hearing more as we're going across the province to hear about that.
Thank you. My apologies, 3 minutes, mic number 2, and we'll get through the rest as quick as can.
Thank you. Sean Kelly, I'm a councillor with the City of Belleville, also a board member with the Hastings Prince Edward Health Unit, long-term care and EMS. Question, and I'll cut right through it. I know you've had 5 conversations already with the province, still 9 to go, and we've heard about EMS and hospital issues, and this is a good conversation. My concern as a councillor is public education and public health towards access to drugs for the youth, and what it's doing to mental health, how it's affecting our hospitals, how it's affecting our municipal police forces. Have those conversations when you're traveling across Ontario. Are you meeting with police departments? Are you having that conversation with counselors and educators that have, at least in my neck of the woods, that have a direct relationship with the youth? So I'd like to know where we're at with that, and are we having those conversations, because we all know that it's tough times right now for a lot of municipalities, and mental health is at the forefront, and I'm just hoping that that's part of the conversation. Thank you.
Yeah, I'll let David speak to this, but I think what we're hearing is that public health units themselves across the province are very much seized with that issue, Sean. So there's lots of local work going on around that particular topic. We haven't had police departments at our sessions yet, but I think that's not to say that people aren't engaged in that important topic. And I don't know, Dr. Williams, if you wanted to add, or
just that the aspect of mental health is on everybody's mind as we're dealing with the issues. We have just getting formed our aspect of mental health and addictions in the Ministry of Health and Long-Term Care. That's a major endeavor that's been undertaken at this time, and there's lots of conversations occurring. The input we've had is from municipal leads and mayors, of course, who some have police departments, and I've indicated the concerns about the responsibilities. Public health really wants to know, in the primary role of prevention and dealing with all those aspects there, where should public health be? How should it be involved in it? How should we be resourced on it? All these aspects, especially dealing with the opioid crisis and different aspects. So it's a very engaging, very wrenching discussion, and I think the community writ large and all the sectors are and have to be involved in this as we go forward. So we're looking for input. We've had some good input, and we're waiting for more on that, especially in pertains to public health in that aspect. So thank you for bringing that point.
Thank you, Dr. Williams. Mic 1, please.
Thank you. Hi, Dr. Williams and Allison and Jim. It's Renee Lapierre, City Councillor for Sudbury, as well as Chair for Public Health there. So just, I had about 19 questions, but I know we're out of time, so I'll bring them down. First question, have we looked at the model of STARS with Alberta Health Services? Orange Transport Medicine is world-renowned for what they do. I know they need tweaks, and I'm all about tweaks, but have we looked at other models in other provinces across the country to be able to see what they do with urgent and non-urgent transfers? Second one is the funding formula for EMS. Are we looking at time on tasks? Because in Northern Ontario, we do 12,000 calls and around the Greater Sudbury, but the time on task for one call is an hour and a half to 2 hours. So our costs are double that compared to, I worked Hamilton EMS for 8 years, and we could do a call in 17 minutes sometimes because you were across the street. So excluding offload delays. And the last one is, Dr. Williams, have you looked at the Northeastern Transformation paper for public health that was put together? And I know that was done in a previous government, but is that still an active document that you guys are looking at as the panel experts to be able to use as guides?
I think the answer is yes on that one. David?
Yes, we have been involved even before the consultation, and then we've had the session in North Bay, and aspects were presented. Jim was aware of that and have the documents, so it's been received, as well as some other consultations in the province. So the more that comes in, the better. Thank you.
And we're definitely looking at other jurisdictions and how that can help, because we think that should also inform Jim's advice as well as what you have to say. And on the third piece about funding for EMS and whether it adjusts for things, I can tell you, as Assistant Deputy Minister coming in and looking at budgeting, when I asked about the funding formula for paramedic services, it was fairly simple. Take municipally approved budgets, divide by 2. And so that's the discussion that we've had. And so the time on task and factoring it in is presumably factored into your budgets. I think we can do better on how we fund and how we show equity across Ontario. But at this point, it's the funding for paramedic services really is based on the budgets that you provide. And so I hope that you're thinking about time on task in that.
Thank you. We are out of time, but the panel has high-signed me to say they'll take question from Dan and Arnprior at mic 2, and then we'll follow with question 1, or mic 1.
Thank you, Peter. It's Dan Lynch, councillor from Arnprior. My questions are really simple. How did you get your criteria to go to the different towns and cities that you're going to? And the reason I ask that is we're from the county of Renfrew. We have Indigenous, we have the bilingual, and we're in the middle of nowhere in the biggest county, yet we have to go to Ottawa or Kingston. Thank you.
Yeah, I don't mind taking that one. Thanks very much, Dan. It really is a pretty simple formula. We tried to limit the travel distance to about 2 hours for any, sort of at the extreme in terms of people having to go to a particular location. We've had many of the public health units particularly have asked to come specifically to their communities, and it's just, I'll be honest, it's a challenge to get to all of them, individually. So we sort of settled on the regional approach, and it's generally just to keep the travel distance within a sort of as meaningful or as easy a way as possible, sort of that 2-hour thing, generally speaking. But it's there's no magic to it other than that, I don't think.
Thank you.
Thank you. Mic number 1, please.
Hi, Melissa Sullivan from the Village of Westport, councillor. First, just really quick, as a mother of 3 small children in a very, very small rural community, I thank you so much for your work. I know we hear a lot about the senior and the aging population, but if we want more young families in our rural communities, the paramedic service and our ease of care is really important too. My question was more about multi-jurisdictions as well. I have a lot of family in Newfoundland and paramedics, and even though the funding model would be very different and the municipal partnership might not be a part of it, are you aware of any other complementary provincial consultation with your counterparts kind of dealing with these cross-Canada issues of isolation and rural distances?
Probably you guys are the best to answer that.
Certainly, one of the advantages we do have in the public health sector is that we have a public health network council that has a meeting of all the chief medical officer health across the country. We have many committees made of members from different parts, including some of our public health units sit on sometimes cross committees, and our agencies as well. So we're always comparing when you're trying to look at services in the territories. As compared to larger centers like Toronto, it's the breadth and width of the problem and the challenges, and we're looking for creative solutions, especially when it comes to rolling out quickly public health responses and programs with the challenges of distance geography in Canada. So it's an enlivened discussion, and we're learning more as we go along and how we best use technology to overcome that. So the conversations are there, and there's much ahead of us.
And on the emergency health services front, there isn't a convenient committee, but we've all kind of found each other, and so we're definitely learning from coast to coast the issues that people are facing. In general, I think you could talk about what we've found so far in the consultations on emergency health services, and everybody across the entire country would say, yeah, us too. And so then it's a matter of learning what has worked locally, what were the conditions that fit there, and how can we learn from that. So thank you for your encouragement to keep looking, though.
Thank you. Thank you, everyone. This has been one of the most interesting sessions I think I've ever attended. I've been in municipal politics for 30-odd years, and it's been quite stimulating to watch how this is rolled out. And the questions today, thank you for your patience and the knowledge and passion that you brought to this topic. The questions were as diverse and interesting and broad as our communities are. And so thank you very much for that. And your learning lunches are coming up at 12 o'clock. I'd like to say thank you to Jim and to Allison and Dr. Williams for your time, your energy.
Thank you.
Your obvious enthusiasm for a difficult and I'm assuming challenging and stimulating exercise. And you know, I envy you. I think it would be quite an interesting process. So, and I'm sure everybody here joins me in that envy because you know, just the energy that you bring to the room and that you receive from the room is quite positive. So, on behalf of ROMA and its board and our president Alan Thompson, we'll be making a contribution to the AMO Youth Engagement Program in your name, and you know, I think that's the kind of legacy that all three of you would appreciate. So thank you very much.
Thank you,
Enjoy
Peter.
the conference.
Thank you, everyone. Thanks for your input.